I will discuss on the treatment of hepatitis B virus in Sub-Saharan Africa, an experience in one of the hospitals in Ethiopia. So I came from Ethiopia. So we know that around 60 million people had been infected in Africa, with the majority of them to be in Sub-Saharan Africa. And when you see the prevalence of adults in Sub-Saharan Africa, mainly you can see majority are having a high intermediate or a higher prevalence of hepatitis B virus. And so Sub-Saharan Africa is largely hit, and there are some countries in which there is no available data. And we can see that Ethiopia is one of the second countries with the highest burden of the hepatitis B virus, and followed by Nigeria. And these two countries are having a population of, like Nigeria, having a population of nearly 200 million, and in Ethiopia, around 109 million people having a higher prevalence of these viruses. And we can see that 65% of the burden is present actually in these 12 countries, and the control in these countries should be greater. So as one of the East African countries, we tried to estimate the adult population prevalence of the hepatitis B virus. And this study has used a national seroprevalence, mainly from the STAPS survey, which uses initially the problem is the data or the blood samples were taken for NCDK's survey, but we have seen that each region has been presented in this national seroprevalence data, and we can see that countries like the Afar region, which is in the northern part of Ethiopia, has a prevalence of around 28.8%, and other countries, cities like the eastern part of Ethiopia and also in the west, which borders the Somalia and the Sudan, we're having the next prevalence of around 12.7 and 13.4% prevalence. This survey has shown that the average prevalence of the population is around 9.4, which could lead to around 10 million people to be infected with the hepatitis B virus from this survey. We have tried to look at the magnitude of the different markers of hepatitis B virus among the different study populations. So from this meta-analysis, we can see that the recent survey from the HIV service have shown E antigen prevalence about 0.6%, but the presence of any marker could reach up to 73.1% in health workers and around 67.2% from just health ANC attendants. So higher presence of the different markers had been seen. And the other more important mode of transmission that we have seen that could be peculiar to Sub-Saharan Africa is, in addition to the other mode of transmission, we have seen that the horizontal transmission in children, that could be related to unidentified causes which could be due to the intimate contact among toddlers, could be one important risk factor to find. And there are still risky practices that had prevalent, like the tonsillectomy, local practices, and also circumcision, scarification, body piercing, and polygamous relations. And also in cities now there is an increased practice of tattoo places which are not actually well regulated, and that could increase the prevalence in the use. And I will show you some DHS data from the 2016 which probably show why it's prevalent in some regions of the country, mainly on this thing has been still prevalent, like the female genital mutilation rates. From the 2016 data, it shows still around 65% prevalence in some areas. So we can see some of the regions with higher prevalence, like these regions we are having around institutional level, which loss like 15 to 18%. And the female genital mutilation, at this you can see it's around 65%. And areas where the hepatitis B prevalence, we are having actually the higher rate of female genital mutilation. The country, the Ministry of Health actually is trying to advocate against this, and also to further increase the institutional delivery rate, which is actually better in cities like the Addis Ababa, which are around 97%. So I came from this hospital. It's one of the biggest hospitals in the country, and we set a treatment program. I'll present just a 1 year data and the last 4 years data from this treatment cohort. So the aim of this cohort study when we established was to have or to formulate a simplified form of an algorithm for treatment and care of hepatitis B. And we have used tenofovir from the Gilead Pharmaceuticals. So the plan was to have a decentralized care in the continuum. So physicians to be mainly involved like in the treatment initiation and to follow and to be consulted when there is any danger signs has been present. So, and to be followed and the follow-up, and so the patient management to be mainly nurse-led, and we started this on February 2015. So one of the challenges that we have from the previous presentation also is assessment of the liver fibrosis. So one thing that we have been doing is a liver biopsy, and it was really difficult, even in many things, the challenges of the liver biopsy in even having a reliable laboratory data, and the different inter-observer variabilities of the pathologies could also hamper the result of liver biopsy, and it cannot be decentralized. And the good alternative, even though it's expensive, is a FibroScan machine. So we are able to get a FibroScan machine, and we have used the liver fibrosis assessment mainly using this FibroScan. So this was the algorithm. We put in red the gray areas, in the orange, and the green areas to be seen like in green. So that these are green are patients who don't need actually early treatment or urgent treatment. So, and the red ones are, so the treating nurse or can inform the physician for early visit of this patient. So in the red we have actual patient, it depends on the ALT, the FibroScan, and the viral load value mainly. And when the ALT level is more than 2 times the upper limit of normal, and viral load more than 2,000, or based on a FibroScan and higher viral load level, and HCC and viral load, and the cirrhosis of any level, whether it's compensated and decompensated. These are the red signs. And the physicians will come and evaluate the patient and rule out any other contraindication to start treatment, and this patient will be offered treatment. But there are still gray areas, so this patient will have evaluation for ALT, viral load, and FibroScan. This patient may end up in red, or they may end up in the green side, which just needs a follow-up. And the green one patients are actually the inactive carriers or the E-negative infection. We also measure the E antigen, and if it's positive, we need to assess whether there is persistent ALT or not in these individuals. So for the first year, we follow them like closely. We do the liver enzymes like every 3 months, and the viral load and FibroScan every 6 months. This is for the first year, and after the first year, actually, it will be the follow-up every 6 months. So what have you found from this 1,303 chronic hepatitis B patient in the cohort? So we have seen that the treatment eligibility in our criteria was 25.2%. This number could be actually higher than the other studies in the African, which is around 10% and another 15%. And this could be due to the fact that we have started this treatment program in a hospital setup, and at that time there was no treatment program in the country, and so those patients who are desperate enough to get the treatment and who are late actually were sent to our treatment protocol. And when you see the tenofovir effectiveness or a patient who discontinued due to the side effect, only one patient has discontinued in this treatment program, and that patient had actually confounding factors like he had comorbidity, he had hypertension, gout, DM, and he stopped the tenofovir due to the persistent elevated creatinine. And when you see the co-infection rate of hepatitis C, it was 2.1%, Hepatitis D virus was 1.4%, and HIV was 0.8% in this cohort. And E antigen status for those who have the E antigen was 90.7%. So like other African countries, there is more E antigen negative prevalence. For those who has genotype, so 85% was genotype A, and 15.2% were genotype D. When we compare the two values based on treatment eligibility, so being an older age, gender, high viral load, the presence of transient elastography being higher, co-infections, especially hepatitis D, even though it is a small number, hepatitis D prevalence, and the other transient non-invasive markers like APRI and FIV4 were associated with the increased treatment eligibility. And so when you follow up these patients in the viral suppression and fibroscan, we have shown that the treatment is really effective and no resistance has been detected. We use viral load cutoff around 69 to compare with the other studies. So 85% had a full viral suppression after 1 year of treatment. This just to show the importance of the adherence and the viral load in the treatment program. When you see these two values, the viral load at the initiation of treatment and adherence, which this we have used the pill count protocol which had been used for the HIV study. So good adherence were associated with a better outcome. Actually, there was no resistance, but this patient after 1 year who had still a higher viral load were those who have a poor adherence and initial viral load, which is very high. So this is a simplified criteria that we have used. We just name it St. Paul criteria. And then we try to validate the non-invasive markers like the APRI or the FIV4, and from the Prolifica study, the GPR, which came out to show whether these are reliable to use in Sub-Saharan Africa. So we use our fibroscan machine to compare whether these are really validated tests. So I will have some slides on this. So we have used the GPR, and it shows a better sensitivity than the others, the APRI and the FIV4 value, but still this sensitivity is around 36%, as you see here. But the APRI at the WHO threshold of 2 has shown a lower sensitivity, which is around 10%. And even though the AUROC is around 86%, so this 10% is likely to lead to most patients actually to miss many patients who are in need of treatment. And you can see the AUROC for moderate fibrosis and cirrhosis. They have a good AUROC value, but the problem is they lack sensitivity. And we try to compare with the Prolifica study, which have shown that APRI has a poor diagnostic accuracy compared to liver biopsy in a cohort of West African patients with chronic hepatitis B. This is really an alarming data because the sensitivity in the Prolifica study was also for significant fibrosis. It was 0% in Senegal and 9% in Gambia. And if you have seen in the 135 Gambian patients with a liver biopsy, APRI at a cut of 2 had a sensitivity of 25% with an AUROC of 0.7. So can we still use APRI as treatment criteria? So that's really a question. So this is one thing that has been said. In God we trust, all others must bring data. So actually it's a problem of the data. I think that the WHO has used APRI, not from Africans, but even from other Asian or from other countries' data. So we have tried to see whether the WHO guideline has comparison to the EASL and to our St. Paul's criteria. So we have used for this around 1,190 Ethiopian patients in the cohort, and we have seen that 300 were eligible for treatment according to the gold standard criteria. So we have used the recent EASL 2017 criteria, and we have seen that 890 were ineligible for treatment according to this criteria, and 147 were correctly classified by the WHO criteria. So 153 were false negative by WHO criteria. This is around 50%. And when you see the performance indicators of the WHO criteria were 49% sensitivity and a specificity of around 96. So this was at a cut of 9.9%. So this had been recommended by the Prolifica study in the West Africa to use. And in other countries, we have seen a cutoff of 11.7 to use cirrhosis. And we have also assessed using the FibroScan cutoff of 11.7% to define cirrhosis. So that had improved the sensitivity from 49 to 51%. So it was not really strong even after improving the FibroScan cutoff value. So this is a crowded slide, but it just shows on one side the EASL criteria and the St. Paul's and the WHO criteria, which has been compared, and we have done the Cohen's kappa for agreement. And you can see the WHO 2015 and EASL 2017, it was 0.518. And when you see the agreement between the St. Paul's and the EASL criteria, it was having a Cohen's kappa of 0.924, and which was significant. So when you see the treatment eligibility based on these criteria, in those cohorts, 25.2% based on the EASL, but 15.3% based on the WHO criteria, and around 23% based on the St. Paul criteria. So it misses like nearly half of the patients who are actually in need of treatment, because if you see in the next slide, so this is the first one showing the in decompensated cirrhosis. So the performance of the WHO in decompensated cirrhosis was 49%. And when the patient have non-decompensated cirrhosis, patient with no ascites or no clinical ascites, but that can be picked, for example, with a higher FibroScan value, so the sensitivity drops to 25.7%. So if you are just relying on APRI and age, ALT 1319, and viral load, then the WHO actually misses patients who need treatment. Like patients with early cirrhosis or advanced fibrosis will not be treated if you rely on the WHO criteria. So the clinical characteristics of patients who are ineligible from these 217 patients, the majority of these patients had significant fibrosis based on transient elastography values. So these are the different characteristics. As you see, cirrhosis and high viral load, for example, 48.4% will be missed. It is nearly high patients. So, but one limitation that I can say from our study also is we have used a gold standard, the EASL. This could also be one limitation, and we have used a FibroScan value as a gold standard for detecting the fibrosis and cirrhosis. So I have some means. So the progress that we have in Ethiopia is we have the national guideline has been adopted, training of health workers has been given. We try to give the awareness campaigns. Hepatitis B vaccination has been given, and there are still challenges on viral load to scale up the treatment program at a higher level, and also the drugs are not still available, and all of these are out of pocket. That's one big limitation in the program in Ethiopia. Currently, there is integration to the HIV case team as of July 2019, and probably we are stimulating the HIV viral load machines to be used. Still, there is a big lack of awareness that patients present late to our care, and an organized data system is very important and crucial to show the real burden of the illness or the disease. And hepatitis B virus birth dose vaccination is not given, and currently we have studied the economical analysis of the birth dose introduction in Ethiopian patients, and we have shown that it is really cost effective, and we want to present it to the policymakers in the country level. Probably this can also expand, and it shows a real economical impact, so we need more data to show that. Screening and viral load tests are very, very big challenges still now. Assessment of fibrosis markers we need to combine data from other African countries, and we are also working with other institutions in Ethiopia so that to have a possible point of care test to assess the non-invasive fibrosis assessment. So if that comes out, that could also be one big help. And we have really lacking tenofovir for mono-infected patients and hepatitis. So this is one of the events that we give in World Hepatitis Day. So we train medical internists who are just yet graduating. A lot of them has been trained. And in conclusion, so the majority of the patients who fulfill the WHO criteria had decompensated cirrhosis. So this suggests that the WHO criteria overlook the opportunity to treat and protect sufficient patients with chronic hepatitis B from decompensation and liver cancer. So as Professor Lacey said, I'll put the term liver cancer here, so that patients will be missed. So recommendation, vaccinate for hepatitis at birth is one recommendation in general, and collaboration efforts, and government prioritization of the health system agenda in other African countries to learn from, like Egypt or from Uganda. And WHO guidelines need refining, and it fails without the appropriate diagnostic evaluation of the hepatitis B viremia. So the other recommendations that it uses is probably not to use also viral load in that guideline, but hepatitis B viremia should always be part of the diagnostic evaluation. Treatment algorithm should be simplified and encompass individuals before the development of advanced fibrosis and cirrhosis. So I would like to acknowledge my groups. This is the ETH NOHEP group from Ethiopia and the Oslo University Hospital. And thank you.